Hello everyone, continuing our discussion on the histopathology of invasive breast carcinoma. We have already seen in our previous class the classification of invasive carcinoma. It is no spatial type, ductal carcinoma, lobular carcinoma, tubular or cribriform carcinoma, mucinous or colloid carcinoma, medullary carcinoma, metaplastic or papillary carcinoma. And we have seen the invasive carcinoma, no special type, and we have seen all the molecular subtypes of it: luminal A, B, normal breast-like, basal-like, which was triple negative, HER2-neu, which was having poorest prognosis, but it was responding to trastuzumab. Till this, we have seen our previous lecture. Now continuing forth. The next subtype is invasive lobular carcinoma. The invasive lobular carcinoma, clinically, it may present as a palpable mass or mammographically densities with irregular borders, but in 1/4 of the cases, the tumor cell infiltrate diffusely and it causes little desmoplasia. The tumor cell infiltrate diffusely to the breast tissue, so there will be no lump and only a subtle calcification on mammogram. Now, it is usually bilateral, or we can say that there is a greater incidence of bilaterality. Now, genetically, now if it is a well-differentiated one or it's a poorly differentiated one, the genetics is different. Well-differentiated one is usually diploid, while poorly is aneuploid. Well-differentiated are ER positive, and poorly differentiated, they lack hormonal receptor. Well-differentiated is HER2-neu negative, like the luminal A1. While poorly differentiated is HER2-neu positive. Well differentiated are associated with lobular carcinoma in situ. Okay, so morphology. Histologically, the hallmark is presence of discohesive infiltrating tumor cells, and they can be seen in the form of sheets, clusters, or Indian file arrangements. So they are discohesive cells. We can see in this diagram. Then tubule formation. Tubule formation is usually absent. It is similar to the lobular carcinoma in situ. Signet ring cells with mucin is present, and desmoplasia is minimum to absent. Here we can see the uniform tumor cell, discohesive cell with stromal invasions, and also Indian file arrangement pattern. Okay, we have to remember this also, the signet ring cell with mucin, and there is a little or absent desmoplasia. Now there are other subtypes of invasive breast carcinoma. We'll see very briefly all of them: medullary carcinoma, mucinous or colloid, tubular, cribriform, or invasive papillary or metaplastic. First of all, medullary carcinoma is usually seen in 6th decade. It's a very well circumscribed tumor with little desmoplasia, and it mimics benign tumor. Histologically, there are 3 characteristic findings. One is syncytiums of cells, to syncytium formation. Second, there is a background of lymphoplasmacytic infiltrate, a lymphoid background is there, and it has the pushing borders. Pushing border means it's a non-infiltrative border. It's very important. It has a pushing border and syncytium formation and a background of lymphoplasmacytic infiltrate. And these are poorly differentiated tumors. Okay, but it has a better than no spatial type prognosis. Okay, and it is also basal-like. We have seen in the basal-like the medullary carcinoma, metaplastic carcinoma are like basal-like. These are triple negative. Okay. Now, mucinous or colloid carcinoma, these are also seen in old age patients. They are slow growing, and grossly it's seen as soft or rubbery. It's also well circumscribed. Histologically, we can see the tumor cell in clusters in a lake of mucin. We can see these anaplastic tumor cells in a lake of mucins. And lymph node metastasis is very less in this, so it is having a better prognosis. Tubular or cribriform, these are usually small sized tumors, like less than 1 centimeters. And they are also mistaken as benign tumors. They have a good prognosis, and these are rare cancers, and they are ER positive cancers. Next is invasive papillary carcinoma. It's a very rare carcinoma. It's ER positive. It has a better prognosis. But the invasive micropapillary carcinoma, it is ER negative and it has a poor prognosis. Last one is the metaplastic carcinoma. Metaplastic carcinoma is again rare. It is also triple negative. So we have seen the basal type is triple negative in NST, and then medullary carcinoma is triple negative, metaplastic carcinoma is triple negative. And metaplastic carcinoma has poor prognosis. Examples are squamous cell carcinoma or carcinoma with spindle cell component. So these are all the histopathological subtypes of invasive breast carcinoma. Thank you.